All right, thanks.
Amber Roberts was 19 years old when she overdosed on heroin. Her father, Michael Roberts, had been planning to take her to addiction treatment on the day she passed away. He was just a little too late. Catherine Cleve was a college student whose mother described her as kind, smart, and hardworking. Her body was found on a concrete staircase in an empty concert venue after her repeated heroin use ended in an overdose. On average, 115 Americans die of a drug overdose every day. More than 630,000 US citizens suffered a fatal overdose between the years 1999 and 2016, with 63,000 of those deaths occurring in 2016 alone. The Center for Disease Control estimates a 14% increase in the death toll, around 72,000 deaths in 2017, equivalent to the entire population of New Braunfels. The current drug policy is to make the possession and use of harmful substances, including opioids, illegal. Ideally, the threat of punishment should be enough to prevent drug use. However, the rising death rates prove that it isn't. The nation needs a stopgap, a way to control the number of lives lost until a better solution can be found. As Catherine's mother, Kay Cleve, put it, "It's too late to save my daughter, but it's not too late to save other kids who will make stupid mistakes, as most of us have done." The first supervised injection room opened in Bern, Switzerland in 1986. There are now over 90 facilities spread across 8 European countries, as well as 2 in Canada and 1 in Australia. Supervised injection facilities, or SIFs, also called drug consumption rooms and medically supervised injecting centers, were created to fulfill several purposes: reduce the number of overdose deaths, prevent the spread of bloodborne viruses, particularly the human immunodeficiency virus, or HIV, increase exposure to rehabilitation and therapy options for drug users, and serve the surrounding community by decreasing the number of used injection materials and public injection instances on the streets. SIFs accomplish this by providing the necessary materials for injection and allowing clients to inject themselves under medical supervision. It is important to note that while the facilities do allow drug use, which is generally agreed upon as immoral, it is with the intention of helping clients to ultimately end their drug use. Often, SIFs run jointly with or extensions of previously established homeless shelters and soup kitchens, allowing them to reach as many patients as possible. Supervised injection facilities would be a useful addition to the United States, but there are specific laws that stand in the way of their existence. The Controlled Substances Act under Title 21 prohibits the use of SIFs anywhere on American soil. Specifically, Section 844 allows the government to penalize anyone caught in possession of illicit drugs, including heroin, cocaine, and other opioids. Section 856 prevents the use of any private facility for drug injection and allows punishment of anyone aware of or involved with such facilities. While states can choose to go around the federal law, and sometimes do, as was the case with the legalization of marijuana in several states, they risk backlash from the federal government. The federal government should amend Sections 844 and 856 of the Controlled Substances Act to accommodate supervised injection facilities in the United States. SIFs should be allowed in the United States for 3 main reasons. Firstly, they increase the chances of recovery for illicit drug addicts by providing information on and referrals for resources ranging from drug rehabilitation centers to social welfare assistance. Secondly, SIFs benefit the overall community by decreasing the number of public injections and removing injection-related waste from the streets. Finally, SIFs are proven to save lives by preventing deaths caused by accidental overdose among their clients through the use of on-site medical staff. Supervised injection facilities should be established in the United States because they provide a better approach to treating drug addicts. An important job of the facilities is referring patients to outside resources like drug rehabilitation centers. SIFs are in a better position to make these referrals than doctors or other sources because the ability to inject drugs in a safe and supervised space draws users in. Studies performed on established facilities often take into account the number of referrals made to patients, as was done with the first medically supervised injecting center in Sydney, Australia. That center refers patients to 3 categories of resources: drug treatment facilities, healthcare consultations, and social welfare assistance. In the first few months, MSIC workers made a total of 1,385 referrals to about 15% of all clientele. Written referrals, which made up about half of the total referrals, were used to determine how often patients visited the referred agencies. The study found that 20% of occasions in which a written referral was provided resulted in subsequent attendance of the patient to the referred agency. Of the 197 clients who were referred to centers specifically for drug treatment, 39 people followed up with the recommended treatment facility. While this number may not be mind-blowingly large, it still represents 39 people who found treatment within just 18 months of the center opening and who may not have entered treatment otherwise. The hope of the Australian facility is that those 39 people would turn into 300 and then 3,000 people, all on the path to recovery. While there are clients who may take advantage of the ability to inject drugs without legal consequences and who may have no intention of entering treatment initially, the study found that users who came to the facilities more often were more likely to go to outside resources. Patients who made more than 10 visits to the MSIC were 18 times more likely to visit one of the referred agencies than patients who visited less. Not only was the MSIC taking advantage of the ability to refer patients, but a good portion of the referred patients were actually following up with the recommended facility and getting much-needed treatment. Similar results appeared in studies done on the first supervised injection facility in North America. Statistics taken by Insight, located in Vancouver, Canada, documented over 10,000 referrals to outside resources in the years 2015 and 2016 combined. Several studies show how many of these referrals from Insight were utilized by patients. One study, based on the responses of patients who had visited Insight, found that 57% of surveyed patients entered or attempted to enter an addiction treatment program after visiting the facility. A second study found that a 30% increase in the use of detoxification treatment, the process of quitting drugs and experiencing withdrawals, accompanied the opening of Insight. The goal is to get all addicts into treatment, and though that goal clearly hasn't been reached in Sydney or Vancouver, the current numbers are a promising start for both. SIFs are just stepping stones toward addiction treatment, but without them, many people may never get the help that they need. Supervised injection facilities should be allowed in the United States because they benefit the overall community by cleaning up used injection materials from the streets and lowering the number of public injections made by drug users. Removing used syringes from public areas lowers the potential for accidental punctures and the spread of infectious diseases, while reducing public injections lowers fear and social rejection of certain areas. All this to say that by achieving these particular goals, the facilities become useful not only to drug users, but also to other members in the community who may have no other connection to them. Many of the European SIFs aim to aid communities in this way, and their reports often record data related to the effects on the surrounding area. One study, done on 5 districts in Barcelona, recorded the number of used syringes picked up off the streets in the months before and after drug consumption rooms were introduced. The first room opened in 2004, with an average of 13.1 used syringes found on the streets per month. Another room opened in the following years, and the monthly average of collected syringes continued to drop until the end of the report's timeframe in 2012. That year, the average was 3.1 syringes collected per month, a 75.6% decrease from 2004. The drug consumption rooms were effectively able to remove used syringes from public areas, lowering the risk of accidental punctures and ultimately making the districts cleaner and safer for residents. Another product of the facilities that benefits the overall community is a reduction in the number of public drug use incidents. Mother Rebecca Beatty and her 4-year-old son witnessed firsthand a homeless man attempt to inject himself with illicit drugs in the neighboring booth of a Subway restaurant in Saskatoon, Canada. Quote, "He pulled out all the supplies to shoot up intravenous drugs. Instantly, my heart kind of fell," end quote, Beatty said of the experience. She went on to assert that if a location specifically for drug users was set up in Saskatoon, the event in the Subway probably wouldn't have happened. Her assumption isn't wrong. Data from client surveys taken in Biel, Switzerland and Geneva, Switzerland compared the most common locations of drug injection in 2000 and again in 2002 after a facility had been established in each city. In 2000, 21% and 18% of users in Biel and Geneva, respectively, were more likely to inject drugs in public places. When Biel users were interviewed again in 2002, only 1 of the 49 interviewees reported mainly injecting in public, while 49% reported using the local SIF most often in the previous 6 months. Similarly, only 10% of Geneva users most frequently injected in public locations, with 29% injecting most often at the established facility. In both cities, the percentage of injections occurring in public dropped. This means more users turning to SIFs, which can again lead them to treatment, and a lower likelihood of experiences like misbeaties. The presence of SIFs can help all members of a community, including the ones who may never step foot in a facility. Measures should be taken to allow the establishment of supervised injection facilities in the United States because SIFs effectively prevent overdose-caused deaths. SIFs are typically equipped with teams of medical staff ranging from physicians to general nurses on site during all open hours. While not permitted to physically help clients inject drugs, medical personnel are trained to see signs of an overdose and respond accordingly. Furthermore, many locations keep naloxone hydrochloride on hand for overdoses with a great potential for fatality. Naloxone hydrochloride is an opioid antagonist that can be injected in emergency situations involving heroin, morphine, and other opioids. It reverses or inhibits the symptoms of opioids, including respiratory depression, which is often the most deadly symptom. These methods allow SIFs to reverse the effects of an overdose before it results in death. Data from several different facilities running across the world support the claim that SIFs save lives by preventing overdose-caused deaths. A study done on Insight in Vancouver compared the number of potentially fatal overdoses that occurred in the facility to the number of overdose-caused deaths in the surrounding area between the years 2004 and 2008. Factors such as the use of naloxone and the need for an ambulance were used to determine whether or not overdoses would have been fatal had they occurred outside of Insight during that time period. A total of 1,004 overdose incidents were managed by Insight during the time period, and 453 of those events were determined to be potentially fatal. While this may seem like a high amount of overdoses, the number is consistent with overdose data from Vancouver before the facility opened. The study estimated that Insight had prevented a range of 8 to 51 deaths during the studied years, an average of 2 to 12 deaths per year. Put in simpler terms, a minimum of 8 people would have died had they suffered overdoses outside of Insight during those years. This is at least 6% of the total overdose mortality burden on the surrounding neighborhood. While the magnitude may not be as great as one would imagine, the study still serves to show that SIFs are successful in saving lives among drug users. The MSIC in Sydney, Australia produced comparable results. The MSIC managed 329 overdoses in the first few months, 81 of which required the use of naloxone. Using factors from other overdose scenarios in the surrounding community, a study estimated that around 13 overdose-caused deaths had been prevented by the MSIC in the first 18 months, between 4 and 9 deaths per year. This number lines up with Insight's estimate of between 2 and 12 lives saved per year. Additionally, as of 2015, the MSIC had managed 5,925 overdoses with no fatalities. Ideally, clients at the MSIC wouldn't be overdosing in the first place, but the medical staff have been proven to be invaluable, and clients who overdose are strongly encouraged to enter treatment to prevent future overdoses. A report comprised of data from all 19 of Germany's facilities found further support for the argument that SIFs effectively prevent overdose-caused deaths. In the years 1995 to 2001, the German facilities managed a total of 2.1 million injection incidents with no resulting fatalities. Furthermore, the study classified 5,426 of the cases as potentially fatal had immediate emergency services not been provided, and overdose deaths documented by police reports show a 9.6% decrease in overdose-caused deaths from 2000 to 2001. The same report also compared drug death rates from 4 specific cities, Saarbrücken, Hanover, Hamburg, and Frankfurt, to determine the actual effect of the facilities on overdose-caused deaths. In Hamburg, the number of drug-related deaths dropped from 184 in 1991, before the establishment of a facility, to 101 in 2001 after a facility opened. Similarly, drug-related deaths in Frankfurt decreased from 147 in 1991 to 36 in 2001. The German report used a time series analysis model, which showed that a statistically significant effect on the number of overdose-caused deaths was achieved approximately 6 months after the opening of each facility. Drug death rates from before and after the introduction of facilities into communities show that SIFs fulfill the goal of preventing overdose-caused deaths. To put it simply, SIFs are proven to save lives. One common concern is that the facilities will bring crime to the neighborhood. This theory is discredited by the results of the 18-month trial report on the Sydney MSIC, which accounted for theft, robbery, and drug-related loitering. The study found that there was a steady increase in crime of the aforementioned kind leading up to the opening of the MSIC, and a gradual decrease in crime in the months after the facility opened. While the decrease in crime can't necessarily be attributed to the opening of the facility, it still shows that there was no great spike in criminal behavior. Logically, if clients are bringing in their own illicit drugs, they are likely funding some sort of illegal drug ring, as they are clearly buying drugs from somewhere. However, this criminal activity doesn't seem to directly affect the surrounding areas of the facilities, as some people think it may. Another big argument against supervised injection facilities is the matter of how to pay for them. Many law-abiding, tax-paying citizens find issue with the idea of their tax dollars allowing someone else to break the law and use illicit drugs. This is a reasonable concern. However, in the long run, these facilities will actually save the country money, as is the case with the Vancouver facility. A study simulated the conditions of insight and determined the overall net savings of the country within 10 years based on 3 benefits provided by the facility: decreased needle sharing, increased use of safe injecting procedures, and increased referral to treatment. With these effects combined, the study estimates a net savings of over $18 million. A similar study took data from existing locations and applied it to Baltimore, Maryland, a city of about 614,000 people. They predict that if an SIF costing $1.8 million annually was set up in Baltimore, it would generate $7.8 million in savings, prevent 6 overdose-caused deaths and 108 overdose-related ambulance calls, and bring an additional 120 patients into treatment. These would be the results of one facility in a single American city. The potential power of the facilities to save lives and money across the nation is incredible. Supervised injection facilities are a much-needed stopgap for the United States, and amending the Controlled Substances Act is a necessary step toward establishing them. The rising number of overdose fatalities every year shows that the current drug policy isn't working. SIFs are capable of benefiting both drug addicts and their communities, and while the methods may be unconventional and perhaps disagreeable, the data proves that the facilities are working. I'm sure we could all agree that drug use should not be supported in the best of times, but these aren't the best of times, and too many people are dying for us to pretend otherwise. The over 500,000 deaths I described earlier may seem horrific, but distant. However, for people living in big cities like Seattle, San Francisco, and New York, those lost lives are all too real. Amber Roberts and Catherine Cleve left behind heartbroken families and friends. They were drug users who made mistakes, but they were also just young girls caught up in the dangerous habits of a struggling generation. It may be too late for them, but it's not too late to make a difference in the lives of the thousands of others making those same mistakes. And this is how. Thank you.
On Ellie's panel, we have my friend Rachel Saylor. Rachel Saylor Garza, LCDC LCSW, currently works as a supportive outpatient counselor at Austin Recovery, a drug and alcohol rehabilitation center. Rachel has experience as a social worker serving clients in both inpatient and outpatient settings who are experiencing challenging life factors including substance addiction, complex family systems, mental illness, grief, trauma, criminal justice system involvement, and homelessness. Returning again is Matt Thomas, who is the CEO of the high-tech data solutions firm JP3 here in Austin. He has been an entrepreneur, executive, and engineer in the high-tech industry for over 2 decades. Matt married his college sweetheart, Andrea, just after completing his mechanical engineering degree at Texas A&M. They have 5 kids, including Veritas non-thesis seniors Jacob and Emma, and 5th grader Jane, along with 5-year-old twin girls, Nevie and Charlotte. Also returning is Catherine Ball, sitting in for Castillo, who does a good job of wrangling the English department here at Veritas Academy, which includes myself and the next advisor, Graham Donaldson, who, aren't you from Saskatoon?
I'm from Saskatoon.
And I'm not going to touch that with a 10-foot pole. So, just going to let that sit. All right, the floor is open. Rachel. You got a mic there next to you so we can hear you.
I didn't hear you mention anything about harm reduction specifically and how harm reduction is effective or not effective versus these specific facilities that are kind of an extreme form of harm reduction. So I'm curious if you did any research on that.
I did. I actually looked a lot into other harm reduction policies, and I believe syringe exchange programs are examples of that, and also housing first programs, which the name implies housing first and then treatment later. And I found that I believe that would be a useful addition to these. That would be something that could work along with these. I think the best approach would be a multifaceted approach to drug addiction. The big thing that I found that syringe exchange programs don't treat that these do is the matter of overdoses. They provide needles, which helps with HIV and the prevention of that, as well as providing treatment and referrals for treatment programs, but they don't specifically provide any real approach to overdoses or lowering the number of overdoses. And that was the big thing that pushed me towards these, was the fact that these are proven to save lives. They actually work, and they're proven to save lives, which the syringe exchange programs and housing first programs don't really work with.
Great job, Ellie. What is the general medical opinion on SIFs in general?
I looked a lot into that, and because I was curious too about what medical professionals think, and I found the American Medical Association, actually, I don't remember what year it was, but they put out a policy stating that they support supervised injection facilities as part of a multifaceted approach, along with other ideas such as treatment diversity, different types of treatment, other unique treatment programs, basically just trying different things to see what works. And they put that out shortly after the Massachusetts Medical Society put out a report that basically looked at all the information they could find on supervised injection facilities, evaluated all the benefits, all the pros, all the cons of it, and they ultimately also decided to support supervised injection facilities should the political temperament in the United States become right for them to exist.
Great job, Ellie. So one of your examples, you talked about a young woman who was found and she had died in a concert venue. So the assumption is that she was doing drugs perhaps while at a concert. So I guess I'm just wondering, what's the profile of the clientele of people who would be going to an SIF? It doesn't sound like an SIF would have helped this young woman because she was going out at night on the town and was sort of doing drugs. So I guess just who are the types of people that are going to the SIFs, and it doesn't seem to cover everyone.
The average profile of a drug addict, especially in the United States, is actually middle-aged white people. There's also a high amount of homeless people who are also addicted. But the 2 girls that I gave examples of they were of an age where they would have benefited from the facilities. And the facilities do see young people come in as well. They don't really treat people below the age of, some of them the cutoff is 18, some of them the cutoff is 15. But both girls were college age and so could have benefited from the facilities. Both of them, I believe, they weren't first-time users, or they hadn't been just using a couple times. They were pretty far along in the addiction process and would have benefited from treatment from the facility.
Great job, Ellie. You talked about this being a stopgap measure, and you gave a number of statistics related to the lives that would be saved. Assuming that we grant that lives would be saved through the SFs, As Christians, though, why should we be supportive of these SIFs? I mean, we're in a sense endorsing something that we believe to be ethically wrong. What's your sort of biblical mandate for wanting to do this? That's my first question.
Yeah, I actually struggled a lot with that myself, kind of wondering where my role is and what I'm supposed to let play out in other people's lives as a result of their sin, and what is my job to step in. And I ultimately came to the conclusion that it is my calling as a Christian to step in and meet people where they are in their sin, in their depravity, because I'm just as depraved as they are, and I can go in and meet them where they are and say, I see you here in your addiction, and I want to walk with you, and I want to be there with you, and I want to treat you, and just really be in this experience with you. And I think that's what the goal of these facilities are. They say, it's okay that you're like this. We're here to help you, and we want to walk with you, and we want to be with you in that treatment, and we just want to keep you alive and see you healthy and as a functioning member of the community, and this is the best way that I believe to do that.
Okay, and so is there data to show that after lives have been saved and after the SAFs have been around for a while and you've had a chance to rescue folks that would have otherwise died, has there been any sort of longitudinal study looking at the long-term effect of those SIFs, and do we see evidence to show that sort of redemptive quality of not just saving a life, but then having them turn their life around? And if so, where have you seen that data? And if not, where would you expect to see it?
It's a little bit difficult to trace the actual path of people through treatment because of patient confidentiality. There's pretty specific rules for patient confidentiality, but I did look into what kind of personal testimonies I can find, and they had a couple videos on the Insight website of people with actual testimonies. And one guy, his name was Dean Wilson. He had been a heroin addict since he was in his late teens. He basically all through his adult life used heroin pretty consistently, and he talked about how in times of stress, in times of when he was really struggling with things, he would increase his heroin addiction, or when his two sons went to live with his ex-wife, he added cocaine into the mix. And he mentioned this comment kind of offhand, but he said, in my case, we have a bad day, we die. And he went on to talk about how Insight basically stops that from happening, basically saves those people on their bad days and keeps them alive. And he actually went on to become treated, and he now works with the facilities and in the facilities. And he talks about how he feels every morning he wakes up and he knows that he has saved someone's life somewhere along the line. And he has friends who followed him into the facility and who he watched go through treatment. And that was a really inspiring story to me. And I feel like those stories are a little bit difficult to come across because of patient confidentiality, but they're absolutely out there.
You did a great job remembering stats and noting numbers. I was curious, you mentioned that in 2017 there was an increase in overdoses in the U.S., and I was curious what the research said about why that was.
Why that was? The biggest reason that I came across was the introduction of fentanyl into the overdose communities, and that's a big reason for why people die. Not a lot of people use only heroin. They usually use some kind of off-brand or something that has fentanyl in it, and that is a big cause of overdoses and death.
Another acceptable answer would have been the election, but anyway.
Yeah.
Okay, so, sorry. Okay, you meant, so these facilities, and I remember now when this happened in Vancouver, there was a lot of back and forth between the city and between private businesses and people who own buildings in the city about zoning and who ultimately gets to make the decision where a controversial building is placed. So can you tell us anything about how that municipal conversation happens in regards to zoning, where this place gets located, how they determine where the optimum place for an SIF to happen is?
Mm-hmm. I'm not entirely sure on the actual process and what committees are involved. I do know that they generally put them in the most high-risk locations, and that's really, they want to put them where they're most effective, and they would probably generally try to avoid residential areas or areas with other people areas with children, things like that. They would want to put them in places, one, where they can reach the most amount of people, and two, where they're not putting anyone else in that neighborhood to harm. I'm not entirely sure of what the whole process, what that looks like, but I could look into that and get back to you.
And then just to follow up with that, anything about the hits or the impacts on local businesses or storefronts, that kind of thing in the neighborhood of an SIF?
On the business side, I'm not all that sure, but I did look into the one portion I talked about where people were worried that if you put a facility like this in a neighborhood, you're going to have drug addicts coming in, you're going to bring more people in who will increase crime rates, increase loitering, increase robbery, and they found that there wasn't any kind of impact like that. It didn't seem to decrease crime necessarily, but it also didn't spike any criminal behavior, which is better for businesses, I imagine.
I think Catherine got it first.
There it is. I'm not really though. Okay. So how exactly would this be funded? You mentioned something in your refutatio about how taxpayers might not be terribly thrilled about their money going to fund these. Would this be entirely funded by taxpayers, or would there be any private interests involved in it? How would this work?
So I generally looked more into federally funded programs. Insight is funded by the, if I can find it, the Health Canada, which is a government department, and it costs $3 million per year. So that's kind of what I looked into is on that side. And what I imagine it would look like in the U.S. is in the Consolidated Appropriations Act of 2016, the government set aside federal funds for syringe exchange programs, which are along the same line as supervised injection facilities. Again, they aren't quite as extreme, and they don't really meet as many goals as these facilities do. But money from that could be used towards this because it's along the same lines of a harm reduction program. In Philadelphia, the nonprofit Safe House is currently trying to open a facility, and theirs would probably be, they're a nonprofit facility, so that wouldn't be federally funded, that would be privately funded. And they might be the first supervised injection facility in the United States, depending on which, there's a court case going on right now, depending on which way that goes. That could kind of set the standard for what it would look like in the United States if they were going to happen.
Did you have your paddle up?
I did, but Ms. Bull took my question, so I'll ask a different one. You quoted some, I believe, a doctors group in Massachusetts, and obviously some of these other foreign groups that were in favor of the SIFs. What has been the response from the sort of Christian outreach community, the programs that already exist to come alongside those who are battling addiction, the folks who run maybe halfway houses or other treatment houses? What have they said about the SIFs, and how do you think that fits into your equation?
That's a great question, and I actually didn't look all that much into Christian programs surrounding the facilities. I more looked into just the facilities themselves, and I did find that they generally are paired with homeless shelters and soup kitchens because that's the best way to reach people. But I'm not sure where they fall on the religious scale in other countries. I think in the United States that would absolutely be a great approach to set up ministries around the facilities. As Christians, that could be a calling of ours, is once these facilities are set up, to see this is an area where we're needed and really group to those people and group to that area and approach that. I didn't see a whole lot of religious correlation in the currently existing facilities, and that may just be because it's not in the U.S. I'm not really sure, but I imagine that could be what it would look like in the United States, would be to have more of a religious correlation.
Donaldson.
Is it fair to say that the one in Bern, Switzerland, 1986, was that the first safe injection site?
From what I found, yes.
And is it still in operation? Is it still happening?
I believe so.
So that's a huge chunk of time. Did they, now I know you've addressed this with client confidentiality, but has that institution, presumably as one of the longest run, and the model, let's say, or the flagship, do they have any literature or data or stats to show what their 30 plus years of operation has done for the city of Bern? You mentioned HIV rates. Any data coming from something that's been going on for a long time as opposed to the one in Australia or the one in Vancouver, which are still relatively recent?
I did look into the Switzerland facilities. However, I looked, from what I found mostly from them, I found a lot on overdose deaths and a lot on the effect on the surrounding areas, so reducing the number of public injections. Those were the main numbers that I got out of them. I didn't get a lot on the actual effects of the treatment, how many people came out, how many people were actually treated by facilities that had been referred to by the supervised injection facilities. Another issue was a lot of their reports are in a foreign language, which was a little bit difficult for me to research. It was hard finding things that I could read or translated versions. So I imagine there's probably a little bit more out there than I was able to find, and perhaps I could learn the language and know a little bit more.
I hear Google Translate is pretty reliable. All right.
Yeah, maybe I'll try that next time.
Well, I was going to ask about just practically clients who are high are challenging to get to remember things. What did the research say about getting those referrals to be effective?
Yeah, I found that in the cases of the referrals, it was better for people to come into the facility more often, and I imagine that's probably part of the case is people who come in once and hear a referral once, it doesn't really stick, but people, especially people who are coming in upwards of 2 times a day, which is the case in some places. Insight, I think, has over 700 people come in per day. And when you're having people come in over and over and over again, it really gives you the opportunity to continue to put those resources in their lives and continue to encourage them towards treatment. And I think that would be a saving grace, if anything, for those people who don't really remember. If they're coming in over and over again, they're getting that exposure more and more often.
Sorry about that. Do you have any fears that this is going to end up normalizing a culture of drug use?
In all honesty, I think the culture right now normalizes drug use more than it should be normalized. I think our current culture uses drugs so much that it's pretty common. And my goal with this is not to make drug use easier or allow drug users to get their high more easily. It's really to get people into treatment and decrease the number of drug users. And I mean, that could be an effect of the facilities, and I think if that is the case, then that would be a time when we could reevaluate and say, look, these aren't working, we need to take them out. But at this point, I think because the current culture leans towards harmful habits like these, it's really the best time to introduce these and just at least see if they work.
Just a quick follow-up to that. What's the relationship between SIFs and law enforcement? Are they allowed anywhere near it? Are police officers, what's the relationship between law enforcement and SIFs, so if we're talking about culture?
The only thing that I really saw related to law enforcement was an article that I read about police officers who were actually helping clients to get to the facility. I believe it was one of the facilities in Canada. Some of the clients, especially in the beginning, were being harassed by neighbors, being harassed by people who weren't fond of the facilities. And the police officers were actually helping the people get to the facilities because they knew the effect that the facilities could have, and they knew the purpose of the facilities, and they wanted to help those people get into treatment. And they knew that those people weren't trying to use drugs and break the law. They were trying to be safe.
A big challenge in social work with the research is that there are so many cultural considerations, and I was curious what some of the research you found about the challenges would be to implement this in the U.S. with all the studies being outside of the U.S.
Like the backlash, you mean? What kind of?
So, I mean, the cultural makeup practically of people in Switzerland is very different than the average American, and just kind of what those cultural considerations would be, or if you did any research on that piece of it.
The only thing that I really looked into in terms of applying these to the United States was the report that I looked at on what it would look like if we implemented one in Baltimore, Maryland. And that one, I believe they did a lot of research and looked into a lot of the different cultural aspects, and their approach seemed to show that they would actually work, at least in Baltimore and Maryland. They would bring, I think the number was 120 patients into treatment in the first couple of years, and they would prevent 6 overdose-caused deaths and 108 overdose-related ambulance calls. And that, I imagine they looked into the cultural differences. I didn't look a whole lot into that, but yeah, that's an interesting question, and I could look into that more.
Can you fit it into 30 seconds, Matt?
Any examples of SIFs being implemented and not working that were
And
shut
not
down
working.
overseas? You mentioned looking at how effective they were. Did you see any that were opened and then closed later?
The Insight was almost closed in 2011. There was a court case where the Prime Minister wanted to have the facility shut down after 8 years of running, and the Canadian Supreme Court actually unanimously agreed to keep the facility open. And other than that, I haven't really seen or heard of any other facilities that closed. I do know that of all the facilities that I studied, there were, and this is just a random fact, there were no fatalities in any of the facilities. So I imagine none of them closed because in general they're successful.
All right, thank you, Ellie.